Thank you very much. And so now we have that opportunity for questions and discussion. And I believe we're a little ahead of schedule as well, so that's good too. As you prepare your questions, I'd like you to come to the microphones. In order for the people who are watching the webinar to hear the questions, we really do need to make sure that everybody uses the microphones which are in the aisles. And I see someone at the microphone already, although with my early cataracts, I can't see who it is. Go ahead. And while you're getting the microphone ready there, I'm going to make sure that everybody formulates their questions in a concise way and has the opportunity to make sure the panel understands the question, and then that we move through the answers in a way so we can make sure everybody has a chance. Go ahead.
Yeah, thanks for your presentation. It's a wonderful one. My name is Li Yang. I know you cover a whole range of issues and aspects, but I think there's some area usually people don't talk about it, but I have followed by several decades. And then I think that's the first involve our budget, actually involve every area of our social issues. The way you talk about their cost of living, the area they live, and the health status, everything is really interrelated. And a lot of issues, they have good families, but they are broken. And a lot of the children, they are adopted instead. They turn out to be the gold medalist. So I think it's where they live, and it's really how do they treated by officials and their communities. It's not based on their families wrong, it's based on our community, our government officials' misconduct. And then some people will say, if you have a government official, you just give them more money and then more law enforcement and more militarized law enforcement. I think that's goes the other way around. And misconduct, wrong and wrong and wrong will not make it right. So I just we have to pay attention to this area. So we have to have enforce the law enforcement in the right way and help establish the family happiness and their cost of living. The way they earn should be the way they can spend to enjoy their life rather than pay a lot of taxation, and that's not enough that you pay a lot of bail and bond and then the whole family broken. So we have to pay attention on these social issues. Otherwise, we are just chasing something that's unsolvable.
Okay, thank you.
Thank you.
So let's have a comment on her comment.
I believe if I understood that correctly, and I may not, we're really talking about the upstream determinants of health. So if we think about the upstream determinants of firearm violence, the fact that we know that there are certain neighborhoods that are riskier neighborhoods, for example, that are impoverished, where people are, there was a great paper in 1999 on young black men, it's the answer, but what was the question? In terms of sort of unwanted people in poor places. So unless as a society we want to address that, which may be beyond the scope of what Kaiser can do, but those are important drivers of the risk for firearm violence and things that we absolutely need to think about.
Appreciate that comment, Terry. Other comments on this?
Briefly, if I again understood your comment, there's now a section in the American College of Emergency Physicians on social emergency medicine. It is dedicated to being better at addressing the social determinants that are evident or maybe not so self-evident when a patient comes to the emergency department, and working with health system leaders to do a better job in the spectrum of challenging issues and crises that patients come to the emergency department with, including a gunshot wound. So this is happening more and more, and again, why I feel strongly that the biopsychosocial model pulls us together to discuss it in a continuum and together, as opposed to What Terry mentioned is in the past is an add-on service. It's integrated. The psychologist is seeing patients with the surgeons together to address some of these issues, and our social service colleagues are integral into addressing this in an effective way. And again, our specialty societies are beginning to more and more address this. And again, social emergency medicine is in its infancy, and it's growing significantly, in this case, in our specialty, in emergency medicine.
Okay, terrific. I think that's David up there.
Thanks, George. David Grossman from Kaiser Permanente, Washington. Is there feedback on this?
Just speak up.
Okay. I wanted to ask Steve a question, and I want to reflect on the panel's very nice presentations, and I maybe want to take issue with one thing, is making sure that we're kind of all aligned around this issue of primary versus secondary prevention. Because Steve, the themes that you embarked on, which is that primary prevention is where it's at, and I couldn't agree with you more. I think that should be a top priority for health systems. But I can't help but reflect that we have a surgeon and an emergency department physician on the panel, and a nurse practitioner who's actually worked, considerably with victims of firearm violence, and want to kind of take that on a little bit to say, isn't it about secondary prevention as well? In other words, if we can't prevent the first episode, then we know that those that have been injured once are at likely risk again. I mean, for example, you brought up the issue of falls prevention. It turns out that the best predictor of future falls is past falls, and that's why they ask you that question. It's very difficult to actually do primary falls prevention because we don't have good screening tools actually to identify people at risk other than whether they've fallen before. So I just wanted to raise that question for some discussion as to are we really talking about primary and secondary or just primary?
Well, that's a great question, David. I was also framing this in the context of our charge at the workshop of primary prevention, but there's no question that the effectiveness of secondary prevention is paramount. And we all know about the victim who comes to the emergency department who's perhaps been injured, and then we don't do a good enough job of preventing the re-injury, the recidivism issues, and so forth. So there's no question that secondary prevention is certainly within our health system's responsibilities to do a better job. And we do know that there is an element of someone injured by a knife, by a bullet, by a fist, who's at risk of retaliating and becoming the perpetrator of an event that we want to prevent too. So those interventions are key in the healthcare system. So I didn't mean to take away from that, but in case of suicide, there's no question about the primary prevention strategy because of its high case fatality ratio. In terms of homicide, it's fascinating. I think it's important for us to stay close to this as a prioritization of primary and secondary and tertiary and allocate funds accordingly, if you will.
Yeah, great, thank you.
Add one thing to that. I agree with everything Steve said, but I think the example of, if they've been, injured, retaliation is an issue. It's not just retaliation that places people at risk for re-injury. So as we think within a healthcare system of steps that we can take from a secondary prevention perspective, it's dealing, I'll go back to the psych stuff, but it's dealing with, we find people whose psych issues aren't helping, they can't sleep because they're having intrusive thoughts, etc. They then go to illicit substances to try to deal with their symptoms, places them at a higher risk for re-injury, etc. So we need to really think about that broadly within health systems.
To the point about secondary injury, I would just share a couple little vignettes. I think when we discharge a patient from the hospital that's been injured, let's say by an accidental discharge, a child, I really think about the other children in that home because especially if it's an accidental discharge or improper storage of firearms, a lot of those attitudes and perceptions around the family structure haven't changed all that much despite such a seminal event in their life of their family. And so the idea of secondary prevention would be not only for that individual patient, but the children that are around them, the children that will be in that home on play dates and, interacting with that family in that space. And so it's actually a huge area to think about broadening just from the patient out to the patient's other family members.
Right.
Morning. Carnell Cooper from San Antonio. Very much appreciate your comments. It's a very interesting discussion. I think that ultimately population health approach to this is ultimately one of the solutions, or one of the possible solutions to it, which I hope we'll get into a bit more in the rest of the next 2 days. But I want to focus for a moment on one aspect that seems to be an overlying theme, and that's the behavioral health. Across multiple parts of this, we've alluded to how behavioral health is an important part of it, and how it is an important part of the solution. One of the big issues with behavioral health is there are not enough of them. In every city across the country, in every aspect, we cannot get behavioral health specialists. So when it comes to healthcare systems approach to this, I would ask one very simple question is, how do we increase behavioral health access across healthcare systems to address not this issue, but other issues as well?
I can start that discussion. You are starting to have a discussion about what I consider a very vexing, challenging area. And the typical way of organizing services is siloing services. So if you've got a behavioral issue, you go over here. If you've got a physical issue, you go over here. And what I find is that, first of all, there's not an integration. In our system, there are health clinical psychologists embedded in trauma surgery, in transplant surgery, in cancer, in pediatrics. It's permeating the system of care, which I think is the first step. Secondly, is training other practitioners, nurse practitioners, psychiatric nurse practitioners, social workers, psychiatric social workers, clinical psychologists for healthcare systems. Because I think we traditionally, in our psychiatry colleagues, we can talk about this because the psychiatry profession is now broadening its approach to behavioral health services so that we have more practitioners embedded in the systems of care rather than going over to some mental health clinic with all of its prejudices or its issues with patients of, I'm not crazy, I just need to help with my physical behavioral issues. So I think we've got to do a better job of integrating behavioral health services, integrating our approach to taking care of patients. We're talking about embedding a psychologist in the emergency department. We now have pharmacists in our emergency department. Why not a clinical psychologist helping us manage these patients with complex behavioral health issues? So we do need to do a better job in this, and it's an important element that is, I think, in its first stages of really growing.
And back just add, the availability is another issue as well. The reimbursement for it, I think, is part of the issue, but just finding one. So we're asking for screening. If I'm asked for screening, if I'm going to do screening in my ED, in my trauma system, I've got to have those folks available for them. So again, from a healthcare system perspective, where do we find those people? How do we get them? How do we get the numbers from not just physicians, right, but social workers, psychologists, et cetera?
Very good. Let me ask a question. In both Steve's presentation and Luke's presentation, one from an emergency department standpoint, the other from a trauma surgeon's perspective, both of you very quickly going to broaden the need for a broader approach than is represented by your location of service. So in your institutions and in institutions like yours across the country, how do you see that integration that was just referred to in Carnell's question beginning to occur? Is it happening in your institution now? Is that a big barrier? Is that part of something that needs to really be high on an agenda, which is how that desiloization, if you will, that's so prevalent to all of healthcare, including yours, how does that begin to occur? So for this topic, talk a little bit about that.
Again, I've been raised in the biomedical model of the Flexner era, and I've, again, of these last couple of years, been obsessed with broadening this model, as you can readily see in my comments. Again, the person who's taken this on is Terry Darun Cassini. She had actually addressed the National Academy's Global Forum on Violence Prevention. She's embedded in the trauma center. She was one of the first in the country to be doing so. So trauma centers can do and need to do a better job of integrating a clinical psychologist in the care of patients who are injured. What's fascinating is that the healthcare system is then looking at her billing issues and saying, well, maybe we should move you away from the clinic where the injured patients are taken and put you in a behavioral health clinic, which is the wrong step to go. But there's financial issues that need to be addressed. But it's a better care of patients to have the psychologist there with the trauma surgeon taking care of these patients. So I think we're making progress in addressing these issues in a comprehensive way. We need to do more. Back to the comment about in the emergency department, there is reimbursement for screening for at-risk alcohol use and abuse. That's been led by Dr. Mello and others. There are opportunities to make that economic argument that we're doing a service, we should be billed for that, and we're making progress in that too. So lots to do, but I think we're making progress.
I would say from our standpoint, or at least from my vantage point, there are so many patient contacts, whether it be in the ambulatory setting or even in the acute inpatient setting for a child hospitalized with not a non-injury disease process, in which we can reach out and actually put materials in their hands, do some of the things that we would routinely do for child preventative mechanisms. Like every pediatrician asks about car seats and about the water temperature in the home and all those sorts of things, but with the issue of firearms, it's almost very taboo, and any mention of it is generally a rote screening process, and there's not a lot of in-depth discussion. So I think if there's a political will on the part of the health system to really tackle this, not necessarily a political will, but just seeing it as a disease process and really engaging with the community, research has shown, even local research done in Atlanta has shown that people really respond well to that. And so I think that hopefully in the coming sessions we'll hear more about some tangible ways in which we can intervene with those patients and their families to put something in their hands, put even material in their hands about safe storage practices and things like that for children.
I'd like to add to this and make 2 points. One is, maybe I'm an optimist. I would like to think that values drive behaviors and values drive financial decisions, so that we have to conceptually get health systems to understand and to value the holistic approach to people, and it's not just injured people, it's people across the health system, and put resources where resources belong. And maybe that's too optimistic, but I'm an optimist. The second point I'd make, and I think let's take our head out of injured patients now and think about everybody. We work in health systems where people have been exposed to various kinds of trauma across their lifespan. And we know that there's an impact on trauma exposure across the lifespan. We should probably be thinking about our provider workforce in terms of infusing trauma-informed care throughout the healthcare system. If we do that, then we take the time to understand what people have been exposed to, the impact on health, the likelihood of leading to another kind of injury, et cetera. We did a quick, at Penn, we did a quick snapshot survey and published it on trauma-informed care and people's knowledge, attitude, behaviors, providers' knowledge, attitude, behaviors, and competencies of trauma-informed care across surgeons, physicians, nurses, therapists, et cetera. We have places to go in building that system to improve the care of patients. That's not behavioral health, like I can deal with really complex mental health problems, but it's a step to start the conversation, I think.
So let me follow up once again on this. I love the way you started, Terry, by saying we have to get health systems to value which means that your sense is they don't currently value, that there's a locus of expertise and advocacy within the institution that's either in the violence unit or the emergency department or the trauma surgery unit. So without wanting to point fingers, do your institutions that you've been affiliated have this as a high priority among all the priorities they address? If not, what's the argument or pathway toward creating that conversation within your institution?
I would not presume to speak for my institution. However, it's going to live forever. I would say I think we have miles to go before we sleep. And I think that sends the message that we have miles to go before we sleep in terms of breaking down the silos and integrating behavioral health. I also believe data speak strongly, so that as we build our knowledge, as we really get data, if we can make a business case for if I'm taking care of a population over time and space, and then I'm not meeting those behavioral health needs and I'm placing people at risk, I'm probably losing money. I'm not a financial person, but I can speak from data and make that case. I think we need to be making the cases within our healthcare systems.
Let them answer, then I'm going to come back to the data question. Go ahead.
Short answer is I don't think entirely that that's a high priority among the healthcare systems that I've been a part of over the course of my career. I will say that framing it very much in the biological terms, as Dr. Hartgarden has done, and very much as a epidemiology and public health issue, and removing all pretext of politics or large macro level policy issues from this discussion potentially could go a long way in getting the C-suite to buy into it.
I think one area that I felt that has moved healthcare systems in population health is with the Affordable Care Act and with the community assessments that they are responding to and partnering with public health agencies. So I see that as a hopeful development where 10 years ago hospital systems leaderships were in selected systems not thinking about population as they are now doing with the Affordable Care Act and its provisions. So I think that's one element of, I see, encouragement. Again, there'll be variations on that as priorities. Two, I think it's an area that's vexing. It's got a lot of other moving things that are not clear to health systems leaders who have varying amounts of population science backgrounds. So it's hard to have people see the value. But I come back to seeing how if they take on social determinants of health in other areas, they see improvements in cancer outcomes. They see improvements in elective surgeries because they've taken into consideration those behavioral health and social determinant issues that the healthcare system values. So I think there's variabilities, obviously, but I think there's movement in the right direction.
That's helpful. I'm going to just follow this line of questioning a little further to make a point. It occurs to me, when I got this call to chair this committee on August 7th, I think was the email, I was not aware of this issue, and I have a longer history as medical director and chief health officer of a large health system. And just as soon as I began thinking about this and talking to people, there are a lot of people within our health system that are aware, but it's not, as you just illustrated for each of your institutions, not necessarily up there. So I would think that one of the challenges we have in terms of helping people to be aware of the burden that this represents might be figuring out how to have that intra-organizational conversation. Now, Kaiser may be quite different. We heard in the introductory comment about they have data, they've looked at the numbers, and actually I've come up with some data for some other health systems, but not my own yet. So, that leads me to the question that you made about, Terry, very important question about information and data and personalizing this to a locality, either a community, I think both of you, all three of you talked about that, or an institution. What does that look like? Is that aspirational? Is it in place?
No, I think actually when I go back to the study I referred to for the 3 communities, we showed what it looked like, and we showed that it really could mobilize systems and get systems to work. I think one of the challenges within a healthcare system is there are many gods to pay and there's competing priorities. So, do we pay attention to everything? What makes firearm violence rise to the top? and know what's the issue in my community, right? One of the things I find in health systems, for example, especially with clinicians, is we tend not to think about firearm suicide because it's such a high case fatality rate, we don't see it come into our health system. Yeah. But that doesn't mean it's not important to our patients and the population. So I think it looks like the willingness to get the data, which is easier to get now because at least we have integrated data, right, in National Violent Death Reporting System and other death sources. And I think Steve's right with the community health assessment, really understanding what's going on in the community and combining that and knowing what's the issue in my health system. Maybe I focus on one thing, but at least it would help me prioritize what to do when I think about firearm violence as a whole.
May create some of those linkages, Luke, that you illustrated in your story with an individual who is involved in a violent episode as a 2-month-old and then later being personally involved. What's the linkage between the various spots? And I think you illustrated that well in your story that could have been linked together in terms of thinking about what approaches could be used.
Can I just raise one quick thought, and this is a little bit scattered, so bear with me, but the notion of, that great quote from George Will about Cal Ripken and prevention and how that may not be as interesting or as sexy, or it certainly can be interesting, but it may not be as immediately evident. Well, prevention doesn't pay that well for a health system. A health system can't recoup expenses or bill on something that doesn't happen. And so changing that paradigm, and certainly depending on the health system, whether it be Kaiser or, my health system, for example, I just wonder if there's ways to connect those dots such that that is more of an actual incentivized thing.
That's probably an open question of whether it pays for health systems under risk arrangements. And so it's the old question that applies to any prevention activity, whether it costs to the system but a social dividend in terms of some of the preventive activities, or whether the intervention actually saved hospitalization. I don't know the answer to that, but it seems to me that's an important kind of question.
I think I mentioned readmissions. I think that's a rich source of study that looks at the behavioral aspects of this individual's challenges with medical issues or injury, and that it's demonstrated that readmissions are reduced, that frequent utilization of emergency services are reduced because they are effectively managed in a comprehensive way. I want to get back to health systems and the challenges of engaging them, because as mentioned, Terry mentioned firearm suicide, it's out there. Again, I found the case report in the New England Journal of Medicine fascinating because it's rare that an individual comes for treatment for a firearm-related suicide attempt. We're engaged in a project where we feel that the health system does have an appropriate role with adopting and translating the Cardiff model into emergency departments and working with public health and community groups to better inform the patterns of assaults that are occurring in a community setting. And the patterns of assaults, whether they be firearm-related or not, could predictably escalate to a bad outcome. The Cardiff model is asking the question in the emergency department, which we always ask: what's your age, demographics, what did you get injured with, what time did you get injured? All those affect clinical care. The question was, finally, in the Cardiff model, where did you get injured? 35th and Burleigh, 11th and Burleigh. I know those are city streets in Milwaukee. Where you got injured is an important element, just like where do you live if you have an infectious disease? Where do you live, the zip code? And so in asking that question, you download that de-identified information, put it on a geospatial coding for the sectors of civil society to discuss, which is what we're doing now in a model community. What I found fascinating about the 4 emergency departments that we've engaged with is the conversion of nursing leadership to say, of course we're going to do this. The Children's Hospital seroconverted immediately. They're asking this question right away. Why? It's for kids. It's for our community. The 2 community emergency departments, yes, I think it is important for us to do, and yet it's been a series of of administrative things to get them to integrate this into the fabric of their emergency department, of asking the simple question, where did you get injured? And our adult emergency department, which is where I've been and leading, I thought that would be the easiest one. That's been the hardest one. These are adults. It's your own fault. You got injured. See ya. So I think there's some real interesting health systems behavioral changes that need to take place where children's hospitals, public hospitals see this. We got to do this. Kaiser Permanente, we got to do this in a way that's meaningfully engaged with our communities. And this is a great example of injury prevention and assault prevention in particular that's worked in other cities in Great Britain. We're seeing how we can adopt this here in the United States. I think that's a great example of how healthcare systems can meaningfully be engaged in the community.
So is there an atlas of violence that's available to each community? Is there a geography of gun injury and death? Is it accessible to the health systems at a level that might be usable? Is it available to those beyond research that might influence opinions and shape points of view on where priorities ought to be set?
Short answer is, in our partnership with law enforcement, this is indeed happening, and the emergency department information complements police information because not all of the cases are known to the police, which is why this is a multi-sectored attempt to better describe the patterns of assaults, to be more proactive, again, not reactionary, proactive and preventive in addressing injuries in a community setting. So we're seeing the law enforcement and public health and health systems play a role. And there was a recent article about health systems utilizing their opioid overdose information, asthma issues in health systems, and there's HIPAA issues that are being addressed because public health is partnering with healthcare systems. So it's real encouraging.
So I appreciate the indulgence of the people that have been standing at the microphone while I got my questions in, and I apologize to them. So, we have plenty of time for conversation, so don't let me dissuade you by getting my points made. But so let's go to the microphone. I will ask the staff, are you going to bring some of the questions from the web? Okay, so I'll count on you to ask them. Go ahead.
My name is Woody Kessel. I'm a pediatrician with the C. Everett Koop Institute at Dartmouth. First, I want to appreciate the panelists in each of your presentations and to try to connect some of the thoughts that each of you stimulated. One of the thoughts is related to falls. We've talked about falls and seniors multiple times. Falls and prevention of falls not only is related to awareness, but there's been some intervention, some engineering that has been put forward. And in large measure because of the dynamics of a fall. Better hand grips, better stairways, better lighting, a variety of things. And Dr. Hargarten talks about kinetic energy. And even with falls, the kinetic energy is a little slower with the fall and the physics than the discharge of a weapon and the untoward consequence of all of that energy. Dr. Neff really talks about and moves us into the realm of firearm safety, thinking not of the acute event, but of the post-event and what we can start to think about. The same issue with falls. What can you do to eliminate the obstacles in your home? Dr. Richmond talks about, frankly, the health system as a community member, and that the health system has a responsibility not just to treat the incoming, but to talk about prevention post-discharge. My question really relates to, Dr. Isham, when you talked about the charge of this committee. Firearms, in that third or fourth paragraph down, seems to be of limited discussion scope in this charge. And what I'm curious a little bit about, we've learned with automobile injuries is that we redesigned vehicles. We put seatbelts in place, car safety seats, collision zones. I'm curious about the limitation about not talking about firearm safety as it relates to the community responsibility.
Well, let me just say that in responding to that comment about the charge, that my example that I selected, tobacco use, to illustrate the opportunity created by this conversation, was very intentional. In the 1990s, the CDC laid out a comprehensive plan for tobacco control. And during that period of time, I remember, because I was involved directly in the conversations, there was a lot of debate about what the most important intervention was for tobacco control. Many people thought at that time, and people still think, and I think is probably still the case, that actually the social interventions and the cultural attitude toward tobacco has been most important in terms of tobacco control. But my response to that was, if that's the case, and that's all, the further you take the analysis, then those of us in the health system can't do a couple of things that are also important to touch many people with respect to helping with that overall broad strategy. And the CDC actually included in its plan a role for health plans and for health systems, hospitals and doctors, even though the conclusion of experts was that the public health interventions were more important. So in creating a conversation, this has nothing to do about what's either most important in the control of this issue or having that conversation. There are many forums to have the other parts of the conversation. But this conversation is bounded by what health systems can do. And we're going to take advantage of all of the opportunity we have during these 2 days to figure out the best way to respond to that charge. So it makes no comment about what's important or not, or that other debate, which is also important. There are many other opportunities and places to have that conversation. So that's how I would respond. Next.
Okay, so we have a number of questions that have been submitted online, and I won't get to all of them, but so my apologies to the people watching online who don't get their questions asked.
Well, we have time, so let's start with them.
So the first one is from Viviana Goldenberg, who I believe is watching from within the Kaiser system. And her question is about primary prevention and behavioral health. Most of the shooters have no previous history of diagnosed mental disorder, but in those cases they have, there are no legal ways to prevent them to access to guns. So how we, primary care providers, could overcome that legal loophole in patients that we screen and seem at high risk of gun violence.
Comments from
I'm not a primary care provider, as my specialty reacts in a specialized way, but I think that's an area of research. I think some of the individuals who have behavioral issues, it's unrecognized. I think adverse childhood events, trauma-informed care does need to be strengthened in a primary care setting. Again, I don't live in this space, but I suspect that this is one of the areas of research, is identifying risk and risk changes from 8-year-olds to 10-year-olds to 14-year-olds. We do know the data on perpetrators of homicide. It starts to peak at age 14, peaks 21, 22, 24. That's very clear, no matter where you live. And there's a great study demonstrating between England and Wales and Chicago, the perpetrators of the exact same age. So I think we know some of that, and we are continuing to explore that. We actually explored that in another forum here at the Academy on violence prevention, global forum on violence prevention, the executive functions being forming. So I think there's opportunities to have the healthcare systems play an effective role in improving their screenings, improving their way of identifying emerging individuals at risk.
I think we're going to see in the next panel actually more discussion of some of those opportunities for identifying risks. And that question sort of gets at one of the questions I generated earlier this morning on my several pages of questions about the different sort of populations that health systems see and what the opportunities are. But we'll wait for that panel for me to ask that question.
I would just echo those comments and say that at the health system level, empowering your primary care providers to really get in the weeds with some of these issues of risk identification, and then providing them the resources and the mechanisms to act on that hunch could save countless lives. So that's certainly an area that needs to be explored.
I think one of the things that we need to consider, as I'm putting myself now, when I'm a patient and I've seen my primary care provider, I've seen my gynecologist, et cetera, and so often the risk assessments are with a technician who's facing the computer and saying, are you being beat by your husband? Yes, no, with no eye contact, no conversation, click off the thing and they fill the risk profile. So it's hard for me to think about firearm violence specifically in relation to screening and the kinds of conversations that have to take place. So I think we need to think not just at higher risk individuals and firearms, but the manner in which we create those conversations to take place within various components of the health system.
We've learned over time in the history, at least I've experienced, the long history, that in pediatric immunization, for example, a number of decades ago, that you don't have a special visit for it, you do it at every opportunity. And we learned in tobacco intervention that if you identify the opportunity to intervene with resources to help quit, you've got to make sure that the provider is not embarrassed by not having an opportunity to connect them to that resource, because they really don't want to look stupid in front of their patient or empower, with lack of power. So we used to call that the easy button issue. When that old ad where you had an easy button kind of response. You have to have an easy button response to these questionnaires, and I think you've one or both of the presentations identified areas where screening was done and information was not acted on in the case studies. But you've got to have the opportunity to do that. And then you have to make sure that whatever you connect them to actually works. So there's a cascade there of issues for us to work through over the course of these 2 days. Next.
Yes. Hi, I'm Dr. Betty Lee Davis, and I'm a clinical social worker who's also a youth violence is a public health epidemic and trauma-informed education activist in the Philadelphia area. And I've attended a number of these workshops and forums in the last few years. And at one of them, I heard Daniel Webster, who I see he's on the program later, when the focus was on mental health and diagnoses and risk. And it was his view that history of violence is the relevant area to explore and not the diagnosis that carries all kinds of problems related to discrimination. And so with that in mind, I'm wondering if history of violence would be one area to look for risk, but also with the trauma-informed model, exposure to violence, and particularly with post-traumatic stress disorder in mind, and how there can be either the behavioral repetition or hyperarousal that can make someone vulnerable to becoming violent themselves.
Information can indeed be a multi-edged object, can it? Go ahead.
Well, Daniel, do you want to say anything? Because you're sitting right there. Sorry, I'm sorry.
Actually, it was quite well said, and I appreciate it. I think it was right on the mark.
All right.
I don't want to hog this anymore.
Well, I think your comment really does reinforce a lot of what we talked about in terms of the integration of behavioral health, but also the history of violence and sort of the violence exposure. So I, again, will reinforce, I think health systems need to really integrate across the entire system, violence exposure, trauma-informed care, et cetera, across the workforce as one way to think about a risk stratification.
I would just say look at our U.S. service members and those veterans that have served over the last, 20 years of armed conflict and the rates of suicide among them and the PTSD I think that's kind of case in point.
Next question.
Hi, thank you all for contributing to this panel and providing me the opportunity to attend this workshop. My name is Ariel Matsangos, and I'm with the Educational Fund to Stop Gun Violence, and I've done previous work as a crew chief and nationally certified advanced DMT, and unfortunately I've had experiences with police officers that I think may have put my patients' lives on the line over whatever legal matter it was that we were discussing. But as you guys know, seconds feel like minutes, and that doesn't matter, and I'll work around you to help my patient. But I think this question may be directed for Dr. Richmond, especially towards the end of your presentation. You had highlighted sources that discuss working with police in response to firearms, and I was wondering if you had any recommendations if you had any recommendations on how to communicate and work with police officers in emergency situations regarding firearms.
I think you're raising an important element of how we bring together elements of civil society, and I make reference to the Cardiff model. In West Dallas, where we're piloting this program, in the room to look at the patterns of assaults is the police chief, the fire chief, representatives from school, social services, sectors of civil society, business, the person who is the association president for the Tavern League of West Dallas. Wisconsin has leadership roles around alcohol-related injuries. That's another subject. But that's where sectors of civil society can come together to talk about how we can make our communities healthier and safer. Two, I think that increasingly law enforcement is being brought into, as the case example that Terry mentioned, in opioid overdoses, they are being pulled in and partnering with EMTs and EMS to provide better, more immediate care of overdose patients. So I think there's opportunities to strengthen how we can help make our communities healthier and safer by partnering with police, with EMS, with health systems across a variety of programs. And I think the opioid epidemic has reached such a level that health systems are looking at ways in which they can strengthen their responses alongside police and EMS. So you raise an important element of partnership in cultivating community responses to a variety of issues, including gun violence prevention.
So I agree with Steve. I think we need to broaden the team, right? We started, Steve's opening thing was we have to go beyond like physicians to other members of the healthcare team. We need to go beyond the healthcare team to the broader teams with whom we interact all the time around gun violence and bring them into the sandbox, so to speak. That allows us to merge data, inform the problem, and take a coherent step forward. The one thing I would say is that the police interaction with patients in our emergency departments and resuscitation areas is an issue. It's certainly an issue in Philadelphia, which is why we sort of took that down. And it's race and poverty and healthcare and police. I think we need to say many of our patients found police were their friends. They got me here fast. They saved my life. They cared about me. We have members in the community who will actually call in an injury, like a motorcycle injury, to the police and say it's a shooting because they think people will get there faster, which is an interesting twist on all of that. But I do think that we need to think about, in addition to merging data informing, if we really care about patients' health and patients' rights, we need those decisions not to be made ad hoc in the emergency department, where I might respond one way and you as a law enforcement officer may respond another way, but that how do we put systems in place in our healthcare systems to manage these interactions that are brought together because of gun violence, and then take it out of the individual provider perspective and make structural decisions for that.
Well said.
Next question.
So this is another online question. Providers are not well compensated for preventive services, but health departments do have prevention in their purview. Please say more about how health systems are partnering with public health to address gun violence.
I've mentioned Cardiff a few times. I think that's a fantastic example of partnership that we feel is a way to be effective. I think public health and healthcare systems have been partnering since the Affordable Care Act and community assessments. So how that's been translated to effective interventions, effective ways in which they can affect outcomes, again, as an area of research, I think it's not been adequately addressed in a way that helps health systems understand their roles to play. I think population sciences are beginning to grow on campuses, again, to inform healthcare systems about what they can do about populations at risk. So I think this is an emerging area that's ripe for credible research and healthcare systems investments.
There's probably experts in the room that know much more about the Affordable Care Act than I do, but I know that there is language that was sort of midnight just before passage of the legislation around the inability of public health systems to specifically ask about the ownership of firearms and things of that nature, and enroll people in prevention mechanisms, and so would just open that up and say that while it is good to partner, there are some things there around that particular piece of legislation that may curtail real movement in that direction.
I'm aware of the fact that I'm sure all of your institutions are involved with public health or may be involved with public health in executing their obligations under community benefit for plans for the community to address needs in the community. And so related to my comment earlier, my question earlier about how this issue rises to a higher awareness at the central leadership of our institutions so that it becomes an item on the table for joint conversations with public health by the institution, and therefore an opportunity to create common focus or partnership focus on addressing it is an opportunity, because there are those linkages made and opportunities made. Beyond that, I'm sure that each of your institutions, I know mine, there are opportunities for partnership at many levels with experts within public health department and so forth, particularly around data and public health data and how it might be useful in terms of being either combined or looked at from the standpoint of the issues in dealing with this issue in your institution. So I think there are a lot of opportunities to be explored in terms of facilitating that conversation.
Hi, my name is Linnea Ashley. I'm out of Oakland, California, and my question is about hospital-based violence intervention programs and the concept of being really siloed in terms of public health systems, and wondering what would help to encourage hospitals and hospital systems to be open to community expertise that isn't necessarily credentialed in a conventional sense, but that is really beneficial in terms of connecting with people who have been impacted by violent trauma through gunfire, and what are ways to help people to kind of bridge that gap to where they don't feel like, this is our area because we are experts, and not recognizing the expertise that sometimes comes from the community.
I think that I'm not going to be able to answer that right now because we have a panel that's going to be discussing it. I think it's a critical, important part of this strategy. And again, Cardiff is all about the community. It's not being led, the discussion about violence prevention is not being led by the healthcare systems. The healthcare systems are providing the information and linking the information. It's the community that's making the decisions. It's the community that's having the discussion. And I think hospital-based programs we're going to hear about tomorrow are good examples of how important the community is in these efforts. So your point is exactly, and the important one to make is the community partnership, community engagement is so important and has to be genuine and genuine in its scope and nature. And I think that's a really important area that I think is unevenly practiced in terms of genuine community engagement.
I think, how many questions do you have on your list?
I have like 3 or 4, but you have time for one more?
Yeah, I think sure we do.
So this one comes from Anna Capito. How do issues of health disparities play into our discussion of gun violence? How do we incorporate discussions of social determinants of health to include interventions on gun violence?
Great research question that is now going to be starting to be tackled here by Kaiser Permanente. Perfect setup.
Well, I think as we talk, like firearm violence is a determinant of health, but social determinants are determinants of firearm violence, right? So we have to incorporate it, and we have to think about it more broadly. A couple examples. One is one of my colleagues at Penn, Sarah Jacoby, published a lovely paper last year in Social Science and Medicine that looked at the old Hoke laws, which was where neighborhoods had different colors where mortgages could be provided from the 1930s. And if you were redlined, it was low resource, unwanted population neighborhoods, and linked those neighborhoods in Philadelphia directly to where our epicenters of firearm violence are right now. So we have to look upstream, and I do think it's inherent on healthcare systems to look upstream. Because our patients live upstream and are affected by those upstream, well, they do, and are affected by those upstream things. I think the second thing is I'm on the Federal Advisory Committee for Healthy People 2030, and of the things that are published now, I can tell you if you go on that website, the framework for that right now is all about upstream social determinants as drivers of health. So we're seeing it really ripple across multiple sectors, I think, at this point.
I'm not a software person, but it's been my thought that when a patient presents to the emergency department to a clinic, there's a lot of information gathered, including the address, zip code of where the patient lives. We've got scores of all sorts of conditions. Imagine now a patient arrives, 51-year-old male, zip code, comorbidities, and you can bubble up a social determinant risk assessment or behavioral risk assessment just by getting additional information from a patient. It seems to me that's where we can go and need to go to better assess patients that present to us. And I think this is an area rich for research and investigation so that busy clinicians can see an assessment that's done for them because the data is there and it can be integrated into a number that assigns a risk that this patient is at risk for a acute MI. We can do those numbers, but why not for other things like injuries and specifically gun violence? I think that's a rich source of opportunity.
Let me agree with that point. I was going to ask that as a question later, actually. My sense is that the contemporary health system does not nearly collect the kind of information it will need routinely in order to be effective in helping promote the health and good health care of the people that they serve in the future. And among them are those social issues. And they come with all sorts of issues around risk in terms of doing that. And there was an RFP from CMS a number of years ago about collecting issues around social factors for individuals and keeping my eye on whether that produces information which is actionable and useful. But I wonder about that in this regard. And I wonder about if that's collecting that information at an individual level is useful. And so I know there are efforts facilitated by organizations like the IHI, the collecting groups that are working with that and trying to produce some knowledge out of that. So that's one point. The second point, I know that in preparing, coming up to speed, doing the crash course on this topic that I did since August 7th when I got the call, I asked Melissa French to send me a bibliography of what we've known at the academies about this. And among them, she reminds me that the Population Health Roundtable that I chaired held a workshop on violence that I attended in Brooklyn, New York. And the whole purpose of that activity is to broaden the scope of awareness of creating linkages between all kinds of constituents, including health systems, with community-focused interventions, because that report was mainly about community-focused interventions. And it seems to me that that's coming into the wheelhouse of health systems, or ought to be coming into the wheelhouse of health systems in terms of being an active partner with others in affecting those. I mean, you can't, my own opinion is that you can't really escape the responsibility for that if you really want to think about having the kind of impact that you have. So I would answer at least on two levels. I'm sure there are other experts that could make additional comments. But any further comments from the panel before we conclude?
I was at a meeting with our practice plan, and there was a healthcare leader talking about the control of diabetics and the A1 levels that are so important to monitor and to make sure that they're engaged perfectly. And this population science of this clinical population so well controlled. And my thought was, well, what if their environment is such that they're at risk of making poor choices about food, about tobacco, and that the healthcare system's natural extension goes beyond to impact this diabetic's performance and outcome by including the community in which that person lives. And I think that's where we're at with this issue of gun violence, is that we can't simply limit our treatment. It's got to go into the community, as we've done with other elements of healthcare, because it maximizes outcomes and improves outcomes of patients.
Oh, go ahead.
So I'm going to say, when I was in my clinical life, I was an intensive care unit nurse, and it always amazed me that we had visiting hours, right, for families to come visit patients, when in reality we were the visitors in patients' lives. So we had it all wrong, right? It was opposite. So as I think now, we often, as people who work in health systems, almost think of the health system as the center of the universe. It's the center, it's sort of our center. I think that's all wrong. Really, the community is the center of the universe, and the healthcare system is there to provide it. So it's the same paradigm shift of, I'm the visitor, not the family coming into the ICU. Healthcare system is not the epicenter of the universe. And I think if we start there, we could make great progress.
Good comment. So this has been a particularly good morning from my perspective. We've, I think, accomplished opening the idea that health systems have a role, and which we're going to explore further in subsequent panels. We've certainly begun to discuss and get people aware collectively of the burden of this issue, the impact of it at multiple levels. And we didn't even explore some of the key issues that you raised, Terry, about economic impact and life course and so forth. I could have gone on for another couple of hours maybe with the questions that I have.
Maybe it'll come up later.
But maybe it'll come up later. We have that opportunity. So keep your list of questions and make sure that we get them into the conversation. We'll have that opportunity. I want you to join me in thanking this excellent panel.